Hello, I'm here to present traumatic experiences and mental health risk for refugees. A little about myself before we get started. My name is Monica Williams, and I'm an associate professor at the School of Psychology at the University of Ottawa, where I serve as the Canada Research Chair in Mental Health Disparities. I'm also the clinical director of the Behavioral Wellness Clinic in Tallinn, Connecticut, and I'm board certified in behavioral and cognitive psychology. I'm licensed as a clinical psychologist in Pennsylvania, Virginia, Connecticut, and Ontario. So I wear a lot of hats and I stay pretty busy, but I have to say that at my heart I am a researcher, and that is what I love to do. So today I'm here to tell you about a little bit of research that was done surrounding the mental health experiences of refugees. When I was the director of the Center for Mental Health Disparities at the University of Louisville, I had the opportunity to be involved in a refugee mental health clinic. And I think that this is really important because as of 2017, there were over 22 million refugees worldwide. And the US government only permits anywhere between 30,000 and 200,000 refugees in yearly, which is just really a fraction of the need. And those refugees who arrive generally are fleeing some pretty severe and dangerous situations. And so as a result, refugees are often exposed to trauma, um, through the process of being displaced, even before that, even after that. And as a result, you have high rates of mental health difficulties, the most prevalent being depression, anxiety, and post-traumatic stress disorder. And so there are some important questions about how do we best identify and help those who are suffering as a result of the refugee experience. It's really important to also remember that language and cultural barriers for refugee populations can be an issue, and this allows many of these mental health issues to go undiagnosed or untreated. So in terms of background here, there are a number of risk factors for mental health symptoms and barriers to treatment services among refugees. And so trauma, as we know, is a risk factor for all sorts of problems like, again, depression, anxiety, PTSD, and a multitude of other problems. One large meta-analysis found that torture and potentially traumatic experiences are the main predictors related to distinct mental health outcomes. And so we felt like it was really important to find out about the experience of torture among refugees. Refugees will also often turn to practices of their culture or trusted community members to aid them with these difficulties instead of using mental health professionals. And then there's a lot of good reasons for that. For one, there isn't necessarily high mental health literacy among some populations, and also different groups may have different explanatory models for distress that may or may not involve mental health. And so cultural differences are paramount, and they may be a factor in mental health outcomes and referral acceptance. So we wanted to look at some of the demographic factors that might be most predictive of mental health difficulties, which will help focus and culturally tailor prevention and intervention efforts. So the aims of the current study were to determine the prevalence of traumatic experiences and positive screenings for symptoms of depression, anxiety, or PTSD by country of origin. Also, look at the impact of factors such as age, sex, and prior traumatic experiences on mental health outcomes. To understand risk factors such as trauma experience, demographic factors, and country of origin to help with prevention and screening efforts. And then finally, identify rates of referral acceptance across nations. So to carry out this study, we utilized the Arriving Refugee Informatics Surveillance and Epidemiology Database, also makes the acronym ARRIVE. And the data was collected from 6 refugee health screening sites in Kentucky between October 2012 and June 2016. And so the ARRIVE database holds information from the Refugee Health Assessment, which is funded by the Office of Refugee Resettlement, to utilize within 8 months of refugee arrival. And agencies really try to complete these screenings within 90 days of arrival. And this process is overseen by the Kentucky Office for Refugees, which ensures that the screening is standardized and that clinics that screen offer referrals and use appropriate interpreting services as needed. So the clinics that provide the screening must submit their data to the ARRIVE database. Participating agencies include a private clinic, urgent care clinics, university clinics, and federally qualified health centers. The full sample includes over 8,000 individuals with immigration statuses, including refugee, entrant, asylee, and special immigrant visas. And I should point out that this study was approved by the University of Louisville IRB. So in terms of our methods, measures that we used for this study included the demographic data, which included age, sex, country of origin, immigrant status, and information regarding acceptance of a referral for mental health services once that was offered. And the RHS-15, which I talked about earlier, this is created by a group called Pathways to Wellness. It's 15 items and includes 13 symptom items, 1 item about coping, and a distress thermometer. And as I mentioned before, this instrument is available in several languages, including Arabic, Burmese, Karen, Nepali, Somali, Farsi, Russian, French, Amharic, Tigrinya, Swahili, and Spanish. And we had definitely made use of the many different languages this measure was involved in, that this measure is translated into. Additional questions were added because we wanted to find out more about some experiences which we know are particularly traumatic. For example, we asked if each participant had experienced and witnessed imprisonment, torture, or violence. And we said, have you experienced imprisonment, torture, or violence, or have you witnessed someone else experiencing torture or violence? And then a follow-up question about each experience was asked with the option to provide more details if they chose. For example, have you experienced imprisonment or have you experienced torture? So the frequency of traumatic experiences and positive mental health screenings were determined by country of origin. Logistic regression was used to examine which demographic factors and traumatic experiences predicted a positive screening. And in this sense, positive is not good. It doesn't mean a good screening. It means a screening where they were flagged for being in need of follow-up. Then we investigated the rate at which refugees accepted referrals if their screening was positive, and this was calculated by the number of patients who accepted the referral over the total number of positive screens for a given nationality. And then we correlated age and sex with referral. Correlations of age and sex with referral acceptance were conducted. Missing cases were deleted from the applicable analyses. And here are our results in terms of positive screenings and frequency of trauma. The mental health screening, again, was completed with over 8,000 refugees, 8,149 to be exact, with 22% endorsing a positive screening, meaning a score of 12 or greater. The nationalities with the highest rates of positive scores were Syrians, Iraqis, and Afghanis. Refugees from Sudan reported torture, violence, or imprisonment at the highest rate, followed by Iraqis and Syrians. Witnessing torture or violence occurred most among Iraqis, Sudanese, and individuals from the Democratic Republic of Congo. A logistic regression analysis was conducted to determine the relative contributions of age, sex, witnessing a traumatic event, and experiencing a traumatic event in predicting a positive screen. Due to some missing data, this analysis consisted of only 5,278 participants. And the full model was significant. The long and short of it is that individuals who witnessed trauma were almost 3 times more likely to have a positive RHS-15 score, and female refugees had increased odds of a positive screening by 2.24 times. Experiencing trauma was associated with a 1.87 increased likelihood of positive screening. Those who screened positive were offered a referral for mental health care. Only Cuban and Iraqi participants had sufficient referral data available. So Cuban participants accepted referrals at a higher rate than Iraqi participants, and the rate for Cuban referrals was 66% and Iraqi participants 57.8%, but this difference was not significant. However, it's important to note that in other nations that had much lower reporting rates, the rate of referral acceptance varied greatly, ranging from anywhere from 10 to 83%. Age and sex were not significantly correlated to referral acceptance. So the purpose of this study was to examine the level of risk of individuals from specific countries experiencing mental health difficulties, and we saw the highest rates of positive screenings from refugees from Syria, Iraq, and Afghanistan, respectively. In addition, experiencing trauma, witnessing trauma, female sex, and older age were all associated with an increased risk for screening positive. And as I pointed out, the referral acceptance rates varied widely. And it's hoped that this information can aid individuals who provide care to refugees in their screening and intervention efforts. Both witnessing and experiencing trauma or torture were found to be related to positive screenings. We thought that perhaps those who witnessed these acts may be at higher risk than those who were tortured due to survivor's guilt or collectivist values among certain cultures. Not enough research has been done to study how witnessing versus experiencing traumatic events is related to mental health outcomes. Mental health interventions can benefit refugees of all nations, regardless of witnessing or experiencing torture, but resilience factors related to refugee mental health need to also be examined because the more we know about resiliency, the better that we can help prevent or address the fallout of these traumatic experiences. Now, due to small sample sizes, it wasn't possible to effectively compare referral acceptance rates by all nations, and so for this reason, more research in this area is really important. Stigma is often a challenge faced by refugees and is a barrier to mental health treatment, but does not explain why refugees from some nations experience or accept referrals at higher rates. And so the reasons for this disparity in referral acceptance is something we need to study more as well. Future research can clarify policies and actions to be taken by community leaders, politicians, care providers, and refugee agencies to increase referral acceptance. Now, although this investigation provided some important information, there are also several limitations. The RHS-15, even though I really like this measure, it is very limited in scope because it does lack a lot of items that could be important, such as thoughts about self-harm or suicidal ideation or exposure to torture, which is why we had to add a question about that afterwards. So subsequent revisions of this instrument should consider the addition of these items to better capture the full range of trauma symptoms often experienced by refugees. Future studies could also consider using culturally adapted screening measures in addition to the RH15 to understand the benefits of each type of assessment and help us have more data as to why we see the differences that we do see. It should be worth noting as well that we did ask straightforward questions about experiences of trauma, and that might have led some refugees denying symptoms and experiences due to just being uncomfortable with the question and stigma regarding mental health. Therefore, some people may have underreported their true level of symptomology and previous traumas. Further, it may be important to find new ways to assess mental health risks in people from countries screening positive at a low rate. For example, it's possible that, say, Bhutanese individuals endorsed mental health concerns at a lower rate because the way that we did the assessment for some reason didn't sit well with them, or stigma over revealing mental health problems rather than a true difference in symptoms. An additional limitation was the small sample sizes that we had for some subsamples. But hopefully, this study will prove useful in providing information regarding refugees who are at risk for mental health symptoms as it relates to traumatic experiences and demographic variables. Refugee agencies and service providers can use this to prepare appropriately for working with these at-risk populations. It's our hope that planning for these unique challenges and risk factors can help increase access to and effectiveness of the mental health services available for refugee individuals. Here are a few references that I recommend. And on that note, I'll just say thank you. If you have any questions, please feel free to reach out to me at my email address listed there. So again, many refugees enter the country without screening or with only an informal screening, and so they may have unidentified pre-displacement or in-transit trauma, or the result of trauma that persists and exacerbates post-displacement struggles. And so for that reason, early intervention is critical. And one of the tools that we use for this is the Refugee Health Screener, which we also call the RHS-15. I really like this instrument. It's short and it's simple, and it comes in many different languages. And so it's designed to identify refugees who present symptoms that may require psychiatric attention. And it's standardized to create diagnostic proxies for PTSD, depression, and anxiety with pretty good sensitivity and specificity across diverse nationalities. And so one reason this was created was to decrease the investment in time and resources that's needed to do complete, full mental health assessments for every person. And so it's considered an efficient diagnostic instrument because if somebody flags positive, then that alerts us, hey, this is somebody that maybe needs a more in-depth evaluation. But there's still many challenges in identifying refugees. And so we really need to figure out how we can identify those who are of highest risk, and the cultural awareness brought about to reduce stigmas and mental health disparities remains of the utmost importance.